We know swallowing is complex, and we know that disability is complex. And just to spice things up, we know that the swallow changes with age as well. A swallow doesn't have to be technically perfect to be functional. And so people with intellectual disability, they may not have the most efficient way of eating or drinking or swallowing, but if it meets their needs and there aren't any other issues, we don't really need to change anything. It might not be perfect, but if it works, then I think that's really good. The other thing to consider, we probably won't get all our assessment information during just one meal. And I've spoken a little bit about that before, about the environment and figuring out how we best see people across all the natural environments. But we need multiple opportunities to assess in multiple environments. Knowing that people present differently in different environments. So at home, I've worked with a woman who, she sits at home perfectly on the chair, picks up her cutlery and cuts up her meat. She'll pierce the food, she'll chew her food really thoroughly, she'll have a sip of her drink in between the food, perfect, no worries. I see her at day placement and she sits there and waits for somebody to feed her. The day placement staff don't know that she can feed herself independently, very effectively at home, and the people at home don't even necessarily know that she's being fed at day placement. So it's about even bridging some of those communication gaps between the different organisations or the different places that a person has their meal. So we all know the different stages of swallowing. We all know that documentation is really important, and it's really important to comment on all of those phases of swallowing for each consistency that we trial, looking at changes throughout the meal, looking at differences between meals, looking at any kind of differences or changes around different environments, different people, different things around the mealtime. So the next couple of slides are really just our things to think about slides. I figured that as a bunch of speech pathologists, we've all been to uni, we've all done dysphagia, so I wasn't going to go over all of that. But having a look about the environment, which we've covered a lot, but maybe some of the more social things. So who's involved in meal planning or meal preparation? Who prepares the food? Where is the person when the food's being prepared? Are they involved in that process at all, or are they stuck down in their bedroom somewhere else? That food preparation time gives us a little bit of anticipation about our meal, and if we're not involved in it, it changes the whole mealtime experience. Think about how the carer or mealtime partner is communicating to the person about what's happening. And also consider vision and hearing impairment or complex communication needs, which we've spoken about a little bit. Who sets the table? Who organises the mealtime routine? Are there certain places people can or can't sit? Are there certain equipment that people need to be using or don't need to be using? Mealtime placemats, cutlery, what needs to happen around that? Is the person positioned appropriately for mealtimes, and are they repositioned appropriately before mealtimes? We really want to start the meal on a positive note, and so having someone not in the best position to start with is going to make it more difficult as we continue on. Does the person have any choice around their meal? Are they getting a choice around what they eat or drink, or how hot or cold their food is, or when during the day they get to eat, or what textures they get to eat? And how might they communicate that choice? So are they offered, do you want tea or coffee, or are they just given tea because the support worker wants a cup of tea as well? Having a look at how much supervision or support is required, and also how much supervision and support is available. So is the person independent or partially independent, or do they really need support with all aspects of the mealtime process? And how can we potentially work with those people to increase their level of independence if that's something that they're interested in doing? Looking at alertness, looking at the interaction between the mealtime partner and the person, thinking about the medications again, but also when are you offered medication? So if you have your medications just before you eat and drink and they taste awful, do you want to be eating and drinking? Do you want it as a separate experience? And what's best practice from a medical perspective around that is also something that we need to think about. Orientation towards food. Does the person move towards the spoon or the cup? Can they open their mouth? Can they physically move to do some of those things? And what additional support might they require? And again, I've got at the bottom, mealtimes are a social experience. How can we make a difference with the social side of things for the person that we're supporting? So Looking at that oral preparatory phase, how quickly, like what's the rate of feeding, how quickly is the person spooning food into someone's mouth, or how quickly is someone eating independently, how much food is on the spoon, how big a bite do they take, are they overfilling their mouth, is there not enough on the spoon? If we don't have enough food on our spoon, are you going to be constantly spooning food in and increasing your level of fatigue as the mealtime goes on? Having a look at the timing of mouthfuls and breathing, and the carer's skills at timing the breathing and the mouthfuls. Can the person breathe through their nose? Is that an option? Is that not an option? Having a bit of a think about our lip seal and taking food or fluid off a spoon or a cup or off your fingers. I know that I work with one particular client, and she doesn't like the metal spoon in her mouth, she doesn't like the plastic spoon in her mouth, but she's happy to have food fed to her from someone's hand. Not a chance you're getting food or fluid off a spoon, but yeah, she'll have a sandwich from someone's hand, which is what she prefers. And having a think about your saliva, which we've gone on about a little bit. Looking at our control of the bolus, so how and where does the person hold it in their mouth, to one side, have a think about neurology. Looking at that transfer, so does it stay in the front of the mouth for a long time? Does someone have a bit of a tongue thrust which pushes the bolus forward even though they're really trying to swallow it back? Looking at anterior spillage, a whole bunch of bits and pieces around that. Can you separate the food or drink in your mouth if you've got too much in your mouth, or are you going to choke on that, or is it going to come out the front of your mouth? Looking at swallow initiation, looking at awareness, sensory awareness, and what are they having difficulty with? Is there any pain, discomfort, unhappy, distressed? How would the person communicate these things to you? So what might look like pain for one person might not be, or what might look like someone is quite happy, again, might not be. And I guess reiterating that a functional swallow doesn't necessarily mean a technically perfect or textbook swallow. So we're nearly done. The pharyngeal phase, so just again, the respiration, coordination of breathing. When you're thinking about palpating someone's swallow, maybe don't just swoop in with your hand directly on their neck. I often sort of start by touching someone's elbow and kind of moving up to sort of go, oh, see how we go. You know, are you not? If you're not comfortable with this, you're probably not going to be comfortable with me poking around your face or your mouth. Similar process with auscultation, and considering that, you know, make sure the stethoscope's warm or make sure your hands are warm, just so it's a little bit more of a pleasant experience. And then comment as well on what you can and can't observe around laryngeal elevation and excursion. Time the meal, think about how long it takes from the start to the finish, and how many swallows per mouthful does the person take, and can that be different for food or fluid? And again, I guess all your other observations of aspiration and penetration, and think about what's a typical mealtime for the person. You might not necessarily know that, but the carers or support people probably will. And again, distress, discomfort, how do they communicate that they're in pain? So, a couple of barriers and solutions to our overall swallowing assessment. I think we can probably read that ourselves. But I guess overall it's just about figuring out what's not working, and let's think of a way to make it work. And I'll just skip to the end so I can finish on time. I guess these are just one really quick slide on my top tips. They're not necessarily the best things, but they're the things that work for me. So make sure you're prepared before you go to an assessment. Take all your equipment or your trial food and fluid with you, any cutlery you might need, any assessment tools you might need. Get there early, so before the meal time, take some time to get to know the person and get to know what they like, what they don't like. You can do your informal OMA, you can do some communication assessment, you can just develop a little bit of rapport with the person. Consider their own space, be respectful of that, so non-confrontational touch, being aware that having someone really close could be really distressing for somebody. Communicate, that's the big one, communicate in a way people understand, and model appropriate communication to the other people who interact around mealtimes with that person. That fluctuating presentation, I really think that we get that a lot, and make sure you assess across a wide range of presentations and consider that you might need to make different recommendations for different times of the day. So I've developed mealtime management plans before. I've said on a good day, Joey looks like this, so on a good day, you need to be doing this. On a not so good day, Joey looks like this, and on that kind of day, you need to be doing this. Be really creative with your information gathering, take photos, videos, have carers complete data recording sheets, use Skype or FaceTime if you really just need to see someone and you can't do it on the spot. And the other one, which I really value, is teamwork. So recognising that effective mealtime management is really hard, and knowing that if you can at least consult with other professionals in their specific disciplines, we can achieve a more appropriate outcome for a client, and we can make a bit more of a difference.